Welcome to NSG 315 Study Session 2. I'm talking about assessment of the cardiovascular system. Introduction. The severity of the patient's symptoms, the practice setting of the nurse, and the purpose of the assessment are variables to be considered in determining the frequency and extent of nursing assessment required. The assessment of the acutely ill cardiac patient will be different from that of a patient with stable or chronic cardiac problems. The nurse must assess the patient for complications associated with myocardial infarction, screen the patient for contraindication to thrombolytic therapy, and evaluate the patient's response to medical and nursing interventions. For this patient, the health history, physical assessment, and important nursing interventions such as cardiac monitoring and administration of intravenous medications are performed simultaneously. Learning outcome for study session 2. At the end of this study session, you should be able to 1. Discuss health assessment for heart disease. Number 2. Explain the physical assessment for heart diseases. And lastly, number 3. Highlight the risk factors for heart disease. Health history for heart diseases. The patient's ability to recognize cardiac symptoms and to know what to do when they occur is essential for effective self-management. For the patient experiencing an acute myocardial infarction, the nurse obtains the health history using a few chosen questions about the onset and the severity of chest discomfort, associated symptoms, current medications, and allergies. Common symptoms. The following are the common signs and symptoms of cardiovascular disease: chest pain or discomfort, of vaginal pectoris or dysrhythmias. Also, shortness of breath or dyspnea in cardiogenic shock, heart failure, or valvular heart disease. Also, peripheral edema, weight gain, abdominal distension due to enlarged spleen or liver, or ascites in heart failure. There can also be palpitations. Past health, family, and social history. The health history provides an opportunity for the nurse to assess patients' understanding of their personal risk factors for coronary artery, peripheral vascular, and cerebrovascular diseases, and measures that are taken to modify this risk. Risk factors are classified by the extent to which they can be modified by changing one's lifestyle or modifying personal behaviors. Medication. Nurses collaborate with primary providers and pharmacists to maintain a complete list of patient medications, including dose and frequency. Vitamins, herbals, and other over-the-counter medication are included on the list. Nutrition. Dietary modification, exercise, weight loss, and careful monitoring are important strategies for managing three major cardiovascular risk factors: hyperlipidemia, hypertension, and diabetes. Diets that are restricted in sodium, fat, cholesterol, or calories are commonly prescribed. The nurse should obtain the following dietary information: the food preference including cultural or ethnic, typical diet, eating habits, either canned or commercially prepared foods versus fresh foods, and restaurant cooking versus home cooking. Also, who shops for groceries, and lastly, who prepares the meal. Elimination. Typical bowel and bladder habits need to be identified. Nocturnal awakening at the night to urinate is common in patients with heart failure. Fluid collected in gravity-dependent tissues extremities during the day, that is edema, redistributes into the circulatory system once the patient is recumbent at night. Patient needs to be aware of their response to diuretic therapy. Have there been any changes in urination, activity, and exercise? Changes in patient activity tolerance are often gradual and may go unnoticed. The nurse determines if there are recent changes by comparing the patient's current activity level with that performed in the past 6 to 12 months. New symptoms or a change in the usual symptoms during activity is a significant finding. Sleep and rest. Clues to worsening cardiac disease, especially heart failure, can be revealed by sleep-related events. Patients with worsening heart failure often experience autopnea, a term used to indicate the need to sit upright or stand to avoid feeling short of breath. Especially chronic heart failure can be revealed by sleep-related events. Self-perception and self-concept. Self-perception and self-concept are both related to the cognitive and emotional processes that people use to formulate their beliefs and feelings about themselves. Having a chronic heart illness such as heart failure or experiencing an acute cardiac event such as myocardial infarction can alter individuals' self-perception and self-concept. You must understand that the patient's belief and feelings about their health are key determinants to adherence to health regimen recommendation and recovery after an acute heart or cardiac event, according to Idrari, Harari, and Varghese 2001. Roles and relationship. Determining the patient's social support system is vitally important in patient's healthcare environment. To assess support system, you should ask, who is the primary caregiver? With whom does the patient live? Are there adequate services in place to provide a safe home environment? You should also assess for significant effect the cardiac illness has had on the patient's role in the family. Sexuality and reproduction. Although people recovering from cardiac illness or procedures are often concerned about sexual activity, they are likely to ask their nurse or other healthcare provider for information to help them resume their normal sex life. Recovering from myocardial infarction or cardiac surgery have reported reduced frequency and satisfaction with sexual intercourse. Coping and stress tolerance. Anxiety, depression, and stress are known to influence both the development and recovery from chronic heart disease and heart failure. High levels of anxiety are associated with an increased incidence of chronic heart failure and in-hospital complication rates after myocardial infarction. The patient may experience 4 phases of emotional healing after an acute cardiac event, such as myocardial infarction. In the first 24 to 48 hours, patients and their spouses typically experience shock and disbelief. Physical assessment. Physical assessment is conducted to confirm information obtained from the health history, to establish the patient's current or baseline condition, and in subsequent assessment to evaluate the patient's response to treatment. Once the initial physical assessment is completed, the frequency of future assessment is determined by the purpose of the encounter and the patient's condition. The examination, which proceeds logically from the head to the toe, can be performed in about 10 minutes with practice. Number 1, general appearance. Number 2, skin. Number 3, blood pressure. Number 4, arterial pulses. Number 5, jugular venous pulsation and pressures. Number 6, heart. Number 7, extremities. Number 8, lungs. And number 9, abdomen. General appearance. This part of the assessment evaluates the patient's level of consciousness, alert, lethargic, stuporous, or comatose, and mental status. Is the patient oriented to person, place, time, or coherence? Changes in the level of consciousness and mental status may be attributed to inadequate perfusion of the brain from a compromised cardiac output or thromboembolic event, that is, stroke. Summary of study session 2. In this study session, you've learned the following. Number 1, The patient's ability to recognize cardiac symptoms and to know what to do when they occur is essential for effective self-care management. For the patient experiencing an acute myocardial infarction, the nurse obtains the health history using a few well-chosen questions about the onset and severity of chest discomfort, associated symptoms, current medications, and allergies. At the same time, the nurse observes the patient's general appearance and evaluates hemodynamic status, the heart rate and rhythm, and also the blood pressure. Once the condition of the patient stabilizes, a more extensive history can be obtained. Number 2, the health history provides an opportunity for the nurse to assess patients' understanding of their personal risk factors for coronary artery, peripheral vascular, and cerebrovascular diseases, and measures that are taken to modify these risks. Risk factors are classified by the extent to which they are modified by changing one's lifestyle or modifying personal behaviors. The risk factors include medications, nutrition, elimination, activity and exercise, sleep and rest, self-perception and self-concept, roles and relationship, sexuality and reproduction, and coping and stress tolerance. Number 3, physical assessment is conducted to confirm information obtained from the health history, to establish the patient's current or baseline conditions, and in subsequent assessment to evaluate the patient's response to treatment. Once the initial assessment is completed, the frequency of future assessment is determined by the purpose of the encounter and the patient's condition. Number 4, there are two types of risk factors. There is the non-modifiable risks and the modifiable risks. Thank you. We've come to the end of this study session.